Garu, the world-renowned cardiologist, the managing director of Ramesh Hospitals, to kindly come onto the dais and take his seat on the dais. And then we have Dr. Potluri Gangadhar Rao Garu, the president of Indian Medical Association, Andhra Pradesh. Sir, kindly come onto the dais and have your chair on the seat. And now we have Dr. N. Kishore Garu, the former president of IMA Andhra Pradesh. Sir, kindly join the other two dignitaries on the dais. Friends, it's now time for us to listen to Dr. P. Ramesh Babu Garu.
Dear colleague and our dynamic IMA president, Dr. Gangadhar Rao Garu, Dr. Kishore, friend and senior colleague and past president, and many of the awardees who are known for their quality in their respective industries, and audience. I am thankful for this high international quality organizing team, and especially when the jury chairman is a very well known Dr. M.S. Swaminathan. Probably some of you may be knowing that he is a pioneer and a great personality in India who is known for green revolution, and who is an awardee, Padma Shri, Padma Bhushan, and a member of several UK, US societies. And he is known to be a pro-poor, pro-woman, and pro-farming personality. He has started several, he's got a research foundation and has started an agro-biodiversity in Vena district in Kerala. Now, coming to the quality in healthcare, as all of us know, without health, nothing is relevant to us in our life. And whatever wealth, if you have a wealth and you have a beautiful house, beautiful wife, children, nothing is relevant when you are not healthy. So, after birth, till you leave this divine world, it is the health that really matters day in and day out and minute to minute. What is the definition of health? It is not just merely the absence of disease or infirmity. It is a state of complete physical, mental and social well-being. So that is health. Not just not having fever, not having a disease or diabetes is not. You should be in a complete state of well-being mentally. That is more important. So morning you have heard our Honorable Minister Sri Raghunath Garu talking about quality in any type of industry. When it is combined with technology advances, then only you can keep pace with the real meaning of quality. And the next 20-25 minutes I'll try to cover upon the points. What is the healthcare scenario in India vis-a-vis other global countries? And what are the gaps in our country in healthcare? What all is being done in the past few decades? And in the past 2 to 3 years, there are some changes which probably all of you have noticed with the new government coming up, and what are the new initiatives. I try to touch upon that, and how still we compare with the other global countries and BRICS. And what is the importance of quality in healthcare? When we were students of MBBS, we were never talking about quality. we were talking about diseases, hypertension, diabetes, heart failure, kidney failure, how to treat. Our professors used to teach about the medicines and make a correct diagnosis, and then discuss about differential diagnosis and give treatment. But then the real quality with the improvement and the IT transformation, digitalization, and in the past decade we have seen sea change in healthcare industry which we haven't imagined when we were students. So what is the importance of quality? I try to touch upon, and how you can stick to quality with patience, and quality in healthcare being rendered in major cities like Tier 1, Chennai, Hyderabad or Delhi. And what are the difficulties we face, and probably all of us face, in Tier 2 and Tier 3 cities in the past 10 to 15 years? People like us, healthcare was considered merely as an expenditure in, by the many institutions, even the government authorities and all. Earlier, it is considered only an expenditure without no visible returns. But now you have evidence. In fact, I used to argue even 20 years ago with some of the economists and all, when they were getting admitted, saving a life will create a resource and wealth to the nation. But now there are statistics, and then you will see in the subsequent presentation how important is it and how it is neglected sector as far as investment is concerned, because there are no visible benefits as far as the wealth creation is concerned. And it was totally wrong, and probably in the past few years the government has realized, and how it is trying to compensate for whatever the lapses, whatever the deficiencies compared to the other global countries, advanced countries, in which they have given a lot of importance to the healthcare and which resulted in progress of the countries. And what is the current status of public and private health sectors in our country? And you are hearing about public-private partnership in healthcare delivery to the nation, the population, and into the interiors, the villages and the mandals, and how to strike a balance, and what are the difficulties involved in it, and how to overcome. What is the best methodology to see that all the resources, human resources, just now I was talking to Dr. Gangadhar Agar, if you utilize the existing infrastructure in the country and the number of medical professionals, and with all this technology, there is no need to pump in thousands and thousands of crores. With the same technology, as I will present to you, we can prevent 50% of the deaths which are occurring as of now. The proper utilization of the resources, especially in golden hours, or timely treatment, timely diagnosis, will result in absolutely more than 50% reduction. So that you can imagine what is its impact. And then what we have done in the past 3 decades in the city of Vijayawada, and you know what is Vijayawada. It is it is well known for several things, and what all we have gone through in the past decades I try to present upon. I tried to gather some of the most recent data in the past 2 years from all these, from the data presented by all these organizations like World Economic Forum and WHO, Infosys, and also Philips, the Health Perspective subsequent, and then India Brand Equity Foundation. So this is the definition of health, and without health there is no freedom of mind. And every one of us wish and to be healthy, and it is important for everyone. And also all of us wish that it should reach every nook and corner, and as a citizen, as a social being, you expect very reasonably good treatment given to every living and a human being, whether he is rich or poor, whether he is living in cities or villages or tribal areas. But what are the difficulties? See, thinking no, idealistic is different, and what is practical is something different. So, within the available limitations, can we try to achieve, strike an optimal balance for this? If you see in India and over the globe, presently and in the subsequent 15 years, there is a change compared to about 100 years ago from non-communicable diseases to increased prevalence of non-communicable diseases. So if you see this, the cardiovascular diseases, then the chronic obstructive lung diseases, then the road traffic accidents, diabetes, hypertension, cancer, HIV, AIDS, these form the important top listed items on which we have to address. These are all chronic diseases and with several complications interrelated. And is there a methodology, and these are lifelong diseases, is there a method to prevent, wherein you have to give more importance to preventive aspect, and once a person is afflicted with the disease, how to prevent the complications, and if the complications are there, how to treat, identify and treat effectively with cost effectiveness. So these are all the difficulties which either the public sector or the people in the private sector are facing day in and day out, despite the idealistic views expressed on several days that it should be equal, it should be given to every person. And if you see in India by 2030, if you see between 2005 and 2030 almost, compared to the communicable diseases, the incidence and the prevalence of non-communicable diseases is going steadily up, and that becomes the major chunk of diseases. And this is the statistics, and these are the common disorders which we have mentioned already. And though we form about 16% of the world, the global population, the chronic diseases, we are, much more compared to many advanced or developing countries also, even compared to the BRICS. That means our disease burden in Indian population is much more compared to other countries. For example, our cardiac disease, it is 3 times more prevalent in Asians compared to the Caucasians, US. 6 times more prevalent than Japan. Also, we are the diabetes capital of the world. India is the diabetes capital of the world. So all these diseases, and you are seeing day in and out, the dialysis, the chronic kidney diseases, and then in the North Andhra and then Bengal, all these areas and several dialysis being a great national program to establish dialysis units is being taken up. So in other words, we are more vulnerable population, genetically, environmental, or probably educational, or awareness, or right from top down, there is neglect in creating awareness amongst the public and to create facilities to halt these disorders. We will see, I will show you the data, how it was done, and then how the corrective steps are being taken now. So these are all called the lifestyle diseases. If a person has got hypertension, apart from the genetic factors, there are environmental factors, and diabetes related to more of carbohydrate intake, lack of exercise, and then more people with diabetes are more prone to get hypertension, and hypertensive patients are more prone to diabetes, and both the diseases result in cardiac disease, renal failure, and cerebrovascular accident, that is brain stroke and paralysis. So these are all lifestyle disorders moving from villages to urbanization. So resulting in more of salt intake, more stress, more competitiveness, not really understanding the true meaning of life. Now, in the past decade, the World Health Organization has the statistics, authentic data to say that there is a case for investment in public health, and it gives a lot of dividends. Everybody talks about industrial sector. I was talking to CII members here. Healthcare is one of the major industries, and after the IT, it gives the highest employment In our organization, for example, in Ramesh Hospital, we have 2,000 employees. Employment is almost 6,000 members of the families. So it gives a lot of employment, and by providing quality health care to the population of the country and investing appropriately in the places where it is required, the infrastructure, the expertise and the timely communication, telemedicine, with all these things, you can improve the GDP that we will see the statistics, and this is what the World Health Organization says. It is the best investment. When we talk about health, oh, it is unnecessary expenditure. And you know, I will show you what is the percentage of GDP that is allocated in the health sector in the past several decades. And quality of health, as the topic of today, is very important, because if you see, all of us think that our ancestors were living healthy 100 years, right? No. In the Stone Age, in fact, it was 13 years was the average life in some of the areas, and it was 23 years in some of the areas. But now, in Japan, it is 85 years average life expectancy, and in India, around 68 years. So how all this is achieved? This is achieved because of the advances in science, because of understanding of the science, because of proper application of the scientific knowledge, and in advanced countries where health consciousness, health awareness is there, they are living longer. It is not only living longer. We see patients now, even in India, some of the patients come, you know, with in-shirt, tie and all, they are very, very jovial, and then they look like 50s and 60s. When you ask them, I am 80-year-old. And when you say, okay, you have disease, you want to get operated, yes, I'm ready for bypass surgery. Triple vessel disease, 80-year-old, we have operated. So the whole scenario is changing. It is the biological age rather than the chronological age. And if you are given good genes and avoid unnecessary bad environmental influences and try to preserve your health, you are likely to live for 100 years, you are likely to work for 100 years also. So that is the concept of science, medical science and technology now. Now, what is quality? What do I mean by quality? In fact, when I started my practice in 1988, I was not really knowing so many issues are there with regard to quality. We were not having technology at the time. In fact, when I started, I was not even having a ventilator in 1988 in Vijayawada. And I have lost some of the patients because I was not having a ventilator. I was not having a cardiac catheterization laboratory where acute heart attack patients, we were just giving some injections. Now we know, with a patient comes within 1 hour, so-called golden hour after chest pain, 98% of the times we can send the patient alive out of the gate. And they can get back to their work within 5 days, their office work, family, everything they can get back if they come within 1 hour. So this is where the technology, the expertise and all these come into factor. Now it is not only the efficiency, the efficacy, the effectiveness. You may have expertise, you may have efficiency, but then is it effective? The systems of care. It is not only having infrastructure, technology, people, but systems of care. Turnaround time of an investigation. Turnaround time when the patient comes to, many patients keep waiting in our OPDs and then they go home, you know, with a lot of, bad experiences of waiting. We are trying to reduce the time. Likewise, not to mistake right side for left side or not operating on right leg, left leg. So time out. So all these qualities, in the past 5 to 6 years, when we started thinking really of quality and trying to acquire the NABH accreditation, that is National Board for Healthcare Providers. When we tried to do that, then we realized there are certain things, certain lapses in our organization and the people. So we tried to document everything and then tried to be effective utilization of all the resources and the expertise. So it is the optimum achievable result for each patient, avoidance of iatrogenic complications and attention to family and patients and in a manner that is cost effective and reasonably documented. And whether it is day or night, whether it is weekend or festival, we have to provide quality care. If a person travels by air, there is a chance that he dies. There is 1 in 10 lakh chance that he will die because of air traffic accident. But in US and in also advanced countries, of course in India, on a weekend, on a festival day, or during the night times, patients admitted in ICU have a higher chance of dying because you don't have the senior most expertise in this during these times. So quality means you should be able to provide care which is in consonance with the scientific evidence-based medicine all through the day, all through the night, and whether it is weekends or festival days or in emergencies or any type of patient. It's extremely difficult. You have to have almost, you see the other day when NABH people have come, they said, you have almost 1.5 times the staff that is required for a standard hospital. Why do you have it? And then we tried looking at it, we were unable to reduce the staff. If you have to give extra time, all these hours, you want to give the expertise, you need to have, 2 experts instead of 1 expert, because you can't have the 365 days and 24 hours with 1 senior expert. You need to have a second. Likewise, a technical person, a paramedical person, all these technicians, and then cath lab, and then senior lab technicians, perfusionists, all these people, you need to have double. Similarly, when we started here in Vijayawada, the first cardiac surgery in 1996, we had to buy all the equipment in duplication, because in Hyderabad people are buying with only 1 equipment, because the service engineers were there in Hyderabad, but we can't get them. If it fails, the operation will fail. So I'll tell you what all we have gone in the subsequent portion. So to achieve in a tier 2 and tier 3 towns, how it is, but it is worth. At the end of the day, we feel very, very happy that we are able to achieve something which is what we mean by quality. And these are all the dimensions of quality and the 4A concept of quality and healthcare in India compared to the other countries. What all it was, probably the scenario is changing. It is not as gloomy as it looks, as if we are lagging behind some of the indicators, but in some areas we started already showing the improvement, which I will be talking about. And from the non-communicable, the disease mix has become much more, which are more chronic diseases and then more expensive, and then shortfall of physical infrastructure and trained manpower and urban-rural divide, where all the resources, infrastructure, doctors are situated in 30% of urban population, whereas in 70% the rural and mandals, the population is distributed, where only 3% of the doctors are there. And then the other most important aspect, the insurance, the health insurance aspect. Meager 7% of the whole population is covered by insurance. People are not aware, or we haven't created enough impact, the importance of health insurance. Whenever suddenly there is an accident, there is a heart failure, or there is a kidney failure, or a paralysis, patients suddenly look at how much will it cost, and losing the very, very important time, and losing the life of a 40-year-old man or a 50-year-old person who is very important for the family. They think of that, oh, it is costing 2 lakhs. So should we have a lesser type of treatment? Because they haven't thought about the health insurance, which can be bought at a reasonable price. So very, very low penetration. This is one of the major drawbacks, apart from the very low allocation in the health budget. And the only 1% of the hospitals are NABH accredited in the country. That means, which are, of course, some more are coming up, but then only recently this NABH concept has crept in, and the real quality, the importance, people are knowing about it. Okay, so compared to the other countries so far, the health indices, if you take in India, it is 68 years, but it is lesser than the other countries, even Brazil, Russia, India, the China, They have higher. Only South Africa has got 56-year-old life expectancy. Majority of the countries have higher life expectancy compared to India. And then this burden, of course, we have seen. And then the infrastructure. The distribution of the infrastructure in the major cities and tier 2, tier 3 villages is, there is great disproportion, and also the manpower distribution. The medical professionals, the nursing, they are very, very inadequate. And then, as we see here, many people in the villages do not have an inpatient care facility within 5 kilometers. They have to walk, even for outpatient. Many people have to walk to just get a simple medicine, a simple crocin tablet for fever, or for simple, the cough. Now, with the advances in technology like telemedicine, that is the only way. And utilizing the resources, we can definitely address this issue. How we will see subsequently. And then the government support. What was it? It is only 1/3 of the total healthcare expenditure, that to meager 4.1% of the GDP. And this is what the current status, unfortunate status. And what are the challenges, either in the public sector or in the private sector, what we have been doing? The challenges which we face are the material cost, the year-on-year price increase, the manpower to get the expertise, senior most people to deliver, even from the middle range, even for complex surgical procedures to simple procedures, and then technicians, all these. We had to pay double the amount for the technicians in Hyderabad to get, when we started in 1996, we had to pay literally twice what they were getting in Hyderabad. So this is what, if it has to percolate into the peripheries, this is how it has to be done. And we really enjoyed whatever we have done. And then the replacement capex, every 2 years there is a change in technology. So if you have to start when we were learning cardiac catheterization in All India Institute, that was not digital cath lab. But when we started here, we had the first digital cath lab. Similarly, nowadays you have the technology to identify disease much ahead. So all these things you have to keep on upgrading to keep pace, to diagnose early, to give appropriate treatment. And then the power and fuel, you have seen almost in the past 2 years there is thrice increase in the power tariff. So this is another major expenditure for us. Manpower cost, establishing infrastructure, capex, the power and fuel, this is the major expenditure which is incurred to provide quality health care. And what is the current status? Human Development Index, which is measured by educational status, their health status, and their per capita income. If you see, it is India is in much lower level compared to the globe. And as I said, it is only 1% of the hospitals in the country which are Joint Commission International accredited, and about 347 NABH accredited hospitals. And we have 3 NABH accredited hospitals in Vijayawada and Guntur put together. And if you improve the quality of healthcare, this is how the GDP can improve, because increased mentation, increased endurance, physical capacity, endurance, output, and lack of or less of absenteeism, and that is how you increase the productivity of an industry and the nation. And also for employment, productivity, and then nowadays we are talking about health tourism. People from 55 countries come to India. We also had a few patients which we will show you, but this is not very poorly connected so far, and hope this area, capital city, can become a hub for health tourism, where you can improve the revenues from the foreign patients, so that this can be cross-subsidized to our Indian poor patients are below the poverty line. This is what we are targeting at. So these are all the indicators. If you compare with Brazil, Russia, China, South Africa, if you see this, it's a meager 4% of the GDP, out of which only 1.1% has been consistently in the past several years, this is the allocation by the central government. And Niti Aayog has improved it a little bit in this particular time. And similarly, the private and out-of-pocket expenditure is more in our country. So from 1.1, it is almost getting doubled by this in the 11th plan. Compared to that, the 12th plan by the Niti Aayog, there is slight increase in the allocation of the budget. So the situation is not all gloomy. Let us say, so far we have seen the statistics which are very, very, disturbing, distressing and depressing. But probably in the next few years, we have strong belief that we will definitely achieve better healthcare status for our nation, for our society. Already in the past 1 to 2 years, there is significant decline in the infant and maternal mortality, especially in AP. Compared to the whole country, in AP, there is a steep decline in infant and maternal mortality thanks to the health minister, the efforts taken by the health department. And then at one point of time, we were worried that HIV and AIDS is going to occupy all our beds, patients. But it is effectively controlled by certain steps, by creating awareness, Puliraja, something like that, it created some awareness among the public to take all necessary precautions. And malaria, of course, there is upsurgence and then sometimes down. Then tobacco control, it is much better in urban area and also in offices. It has come down significantly, tobacco usage, whereas it is growing in the villages and mandals. And the control of tuberculosis, of course, some drug resistance cases are there, but still there is reasonably good control. Now, you are talking about the number of doctors, the number of medical colleges, and we are drawn into a trap because of the UN Millennium Goals, wherein the WHO has taken from there and said that you have limited number of beds excuse me, and doctors, and that is how there is a cropping up of medical colleges in the past 10 years, but unfortunately the medical colleges did not have sufficient staffing, as all of you know, many people have faced, and then this resulted in corrupt practices at several levels. One consultant working in 3-4 colleges, and then now the corrective steps are being taken. This is why I am telling you this is a trap, because this is based on UN Millennium Development Goals, where the communicable diseases were taken into consideration, and they were advising certain population-based the doctors ratio. Now it is not needed. If you can utilize the people, the doctors who are sitting idle, or who are retired, or who do not have sufficient workload, if you utilize these properly, and if you can connect it to the telemedicine, then one doctor can optimally utilize his time, and then you need to increase the number of doctors. The existing doctors' strength is sufficient to deliver the desired health care by the medical practitioners, medical professionals. Okay? Because of this, the quality of medical education has drastically come down. This is, you must be seeing, there is a report in the JAMA published, and the quality of medical education is very poor in India, at least especially in certain pockets. So we fell into this trap of requirement, desirable goals, and in the past 10 years, many medical colleges have unnecessarily cropped up, resulting in deficit of the quality education and the teachers. So it has to be now, thought about, and then effective utilization of the resources has to be really given a serious thought. So these are the major differences between the advanced countries, where the distribution. In US, if you have to start a hospital, you have to get a license. That there is a requirement compared to the existing hospitals. You need to start a 200-bedded hospital. There is no gap. There is no space for you to accommodate. Go about 50 kilometers or 100 kilometers away and start your hospital there. But here, that sort of licensing is not there, And that thought should be given that if anybody wants to start a new hospital, they should start in a place where it is really needed. So, and then coming to the health insurance market. As I discussed with you, this is a very, very important aspect which is neglected, health insurance. So, because of the inadequate facilities in the government sector, and then the expensive, and everybody wants the best of the treatment, the best of the medicines, the costliest antibiotic, and devices. What is new in research, they want the best. But at the same time, if you see, you have to pay more. So to meet that, even upper middle class people, it will be difficult. And so health insurance has to be made mandatory, even in the private sector. The employees need to be insured. In fact, all our employees now the families are insured up to 5 lakhs. All our employees. So in the past 2 years, many of their family members were treated in different hospitals, and even for dreaded diseases, they are very happy. Otherwise, they would have become permanently debted. They would have taken some loan from somewhere, 1 lakh, 2 lakhs, 3 lakhs, and there is a permanent debt. By the time they clear their loan, it will be their lifetime. So health insurance is mandatory to be made in the private sector or public sector, and it has to be adequately monitored, checked, it has to be effective. And only 7% have health insurance so far. And I'll tell you an interesting phenomenon. All over the country, in the past 10 years, health insurance premiums have gone up in every state. But in our state, we boast of the scheme, the government scheme where Arogyasri and all. India is the only country, the AP is the only state where the health insurance premiums have come down by minus 13.2%, whereas in all other places, including Bihar, there was 40 times more insurance premiums. So health care is unnecessary, is misused by the people also, and to get the quality at a lower level, to get the highest quality, it is not possible. Just let me tell you, it is not possible to get the highest quality treatment with just a nominal fee or no fee. It is not possible because you can't cross-subsidize. And then 80% of the people are covered by this so-called BPL cards. And then, of course, with all these things, still India is considered, healthcare is going to be a booming sector in India. That is how you must have seen many foreign nationals, companies are coming, trying to tie up with the hospitals existing, and to improve further the healthcare and to spread it to the peripheries also, to see that the whole nation is covered by this proper healthcare delivery. And the Indian economy, whatever the small ditch that is there because of demonetization, I am sure, I think many people are sure that it is going to improve. India is going to become the strongest economy in the world. Maybe in 10 years or 20 years or 30 years, it is going to be the strongest. This is what many of the economic experts believe, though there may be some controversy in that. And then there are increasing options for financing and delivery and medical tourism, as I said, and there is increasing demand from within the country. People are now more health conscious, right? Instead of from being the doctor-centered treatment, now it is patient-centered treatment. Many patients come to us with the Google, with the search, this is the disease I have, you have given this drug, why did you not give this drug? So we have to be more update. So this is become now patient-centric, family-centric. Now the communications are so much, the information is so much that you have to be updated, you have to give the best treatment. So the opportunities are increasing, and the upper middle section is going to become much more important segment, and they are going to have better financial strength. And then what is the advantage? Indian doctors are considered one of the best, even in US, you must have heard seen in newspapers. And we have the best of doctors, even in the country who are there, we see in conferences, the presentation, what they do, even now the US and all these people, they are amazed, the number of procedures, the success rate, what we have. So we are in many areas, we are not inferior to any of the international faculty, medical faculty. So expertise is there, quality is there, and most of the advantage compared to China is we are more fluent in English. Our people, nurses, doctors, they are more fluent in English. So this will attract medical tourism, and to understand the technology, to quickly adopt whatever newer things are there. And then the latest medical equipments. We have, as I will show you, some of the equipment which, many of the United States, some of the states do not have, do not possess, and the quality of the nurses and the cost. I'll tell you the cardiac surgeries, the multi-organ transplants which are being performed in India, all of us should be proud of. And the physicians, nurses, next to IT, the health sector is the most important sector. If you see the cost of the surgeries, if you see the bypass surgery, it is $123,000 in US. Whereas for an Arogyasri patient, we do it not this $7,900, we do it $1,500. You compare, that means how much is it? 1/70th of what it is being done. For the same technology, we use the same heart lung machine, we use the same lights, okay? And then we use the same table, operation theater and the laminar flow, but still it is 1/70th. So these are all, you can see, this is the comparison you have. And this is a fact, this is collected by the important organizations in the country. And everywhere, that is how from 55 countries you have medical tourism. Still awareness is not there. Otherwise, many states in the country are capable of treating the international patients, earning more revenue for the country. So another important thing, the digital transformation, so-called e-health. So what is e-health? Most of you may be knowing, and it is the ability, and this is in fact in the morning, incidentally, Dr. Raghunath Reddy was talking about Baranagama movie. This is what it is, in fact. So treating the patient, the blood tests are, you'll get the investigations with very, in an area, and you can get best of the advice. And for simple blood pressure, for diabetes, and all these things, you don't need to do. And if you have telemedicine, what are the advantages? One is unnecessary admissions from the villages. Sometimes we see patients coming from villages, rushing in the midnight at 1 o'clock. They complain of severe chest pain, and then you see it is a muscular chest pain, right? And they consume the ambulances, they consume the cars, and then some patient has got mild discomfort and burning sensation. He waits till morning, he comes, by the time he comes it is already damaged, and whatever you do, some patients die. So only needy patients have to travel, utilize the resources, especially in the night times from the villages and mandals. Now you have a national fiber grid which is coming up, which is going to be a boon for health sector. The greatest advantage with the fiber grid is going to be, the beneficiaries are going to be the people living in the mandals and villages, where hitherto, in fact, I have some of the doctors' friends. Ramesh, ఏదైనా చెస్ట్ పెయిన్ వస్తే మాకు ఏం చేయాలో తెలియట్లేదు, 2 hours దాకా నీ దగ్గరికి చెప్పు పడతామని భయంగా ఉంటుంది మా విలేజ్ ఎవరికి వచ్చినాని. But now there is no need. With a fiber grid, we have ECG. All our cardiologists have cell phone ECGs. ECG done in one of our telemedicine centers, as I will be showing. It can be transmitted anytime in the midnight, and the doctor on duty will see it and say whether it is a cardiac or non-cardiac, and prescribe the primary first aid treatment there itself. This is what we have been doing, and still a lot of awareness needs to be done. And then if you have a tele-ICU, mortality, as I told you, in the night times, in the weekends and the festival days, the proper care is not there. If you have a tele-ICU, doctor who is on call can sit at home. If suddenly some problem is there, he can look at that, monitor, and then say, you give this drug, you don't give this, or you increase the oxygen, you do this investigation. This is our 26% better survival rate in the ICU patients. And faster discharge. Nowadays we talk about patients being discharged early. Okay, average length of stay allows. That is one of the criteria in our NABH. The lower it is, the better it is for the patient, because infection rate, and then you are treating it effectively. So effective time, saving methods are utilized by the hospital. So we are looking at allos. So all these things can be achieved by tele-ICU, all these technologies and all. Okay, so the key applications for this telemedicine are telecardiology, radiology, consultation, telepathology, telepsychiatry, teleophthalmology, tele-ENT, and all departments. It is going to have very wide applications. Now, it is, prevention is better than cure. If there is dirt around, and that is a source for communicable diseases, mosquitoes, and then spread of malaria, diarrheal diseases, and then all these things. And the respiratory tract infections, the environmental disorders. So what is happening? So in the past 2 years, the initiative, I feel, with no cost, with the involvement of the people, this is one of the best initiatives as far as healthcare delivery is concerned. Probably, though we are saying it is only 1.1%, we were nagging and what is this low cost allocation. But this is going to have an impact equivalent to at least 1% of the GDP, let me tell you. I strongly believe. Apart from the 2.5% that is allocated by Niti Aayog, this is definitely going to help. It has already started, it has shown, and in Salapalli you can see, you must be seeing in the papers, and likewise in many areas people are doing, and a lot of targets are there. Many youngsters, youth is motivated by this program, and this is the target that is given, and slowly I think this will be achieved in the next few years for different individual sanitation, public, and then all these waste collection purpose. And here, so Mr. Praveen, our Master of Ceremonies, is quoting. So with our dynamic visionary Chandrababu Naidu, who has started, who was very much, in fact, when, let me tell you, one MP was admitted in our hospital somewhere in 1998 or so. And then he came to visit the patient. So after visiting, he was asking, have you started telemedicine? In fact, to tell you the fact, I was having very, very poor knowledge about telemedicine at that time, 1997, 98. Only at that time in small areas, Ramachandra Medical College and somewhere, they just initiated that. Of course, in the past 4 years, we have taken interest and then we have started. So, with the demonetization also, now in the morning you were saying that e-office, what is e-office and all. Our state is much ahead in this telemedicine, and we are going to initiate the fiber grid. In fact, I was talking to him, and fiber grid in all the villages and mandals in some North Andhra and all these areas. Once that is there, we are going to utilize it to establish telemedicine centers to see that all the patients are treated irrespective of the timing, okay, and at very, very low cost. So this is going to be a great help, great boon to the healthcare sector. And people want growth, but they don't want to change. People want the growth all over, but they don't want to change. But this cannot work. Everybody has to think, act according to the circumstances. And what we have done in the past 3 decades, I'll quickly run through, trying to establish, in fact, when we purchased the $240,000 digital cath lab, that was first in the state. In fact, it was not there even in Hyderabad when we purchased. We were using this Tagarno, this cassette, the real model earlier. And likewise, we have the second machine in the country, that is 256 Live CT, which we can say 15-year warranty test. We can identify a disease, we can identify people who are going to get heart attack with almost 99% accuracy. If the test is negative, then for the next 15 years it is a warranty against heart attack, major heart attack. So likewise, we try to establish state-of-the-art equipment. Then the expertise, trying to get different people, senior people, by paying more, by hiring them for good salaries. And then public health education, and then we focused on rural mandal areas. In 1996 itself, for 20 rupees we are doing the computerized ECG. Likewise, telemedicine, we have 13 centers, started 4 years ago. And then we have participated in FDA approved clinical research trials since 2004. We have completed 13 trials and ongoing trials are there. And then several BLS, we have trained 50,000 school students and college students, paramedical staff and doctors in the basic life support program so far. And of course, CSR activities for the below the poverty line. And we have a education, DNB cardiology program, where 2 cardiologists have passed out already and another cardiologist is being trained, apart from around 40 postgraduate diploma in clinical cardiology recognized by IGNO. And then we have NABH accreditation for our main center, MG Road Center, and then Guntur. We have NABF for the laboratory accreditation for both Vijayawada and Guntur. And we are targeting for JCI. So this is how we started in 1988 until so far, trying to establish, trying to give the best to the people of this area, trying to get the best of the equipment. And this is how we have 2,000 employees and more than 100 full-time consultations, starting with cardiology based, now focused, now we are a multi-speciality. and covering all the departments. And whenever we purchased, it was the first hand machine. In fact, when we purchased it in 1996, the cath lab, it was 7 crore at the time. The 256 slice is $2 million. The 3 Tesla MRI is another $2 million machine in Guntur, what we have purchased first in Southeast Asia. So we never compromised on the quality, though you can get the refurbished machine for about 20% of the cost of these things. So this is how we try to modify. And in the initial phases, as I said, being tier 2, whenever there is a small component in the machine that is gone, then we take the advice. And our people, some of the people sitting here, they were getting from Hyderabad midnight. Either they were traveling by car or sending by 11 o'clock bus. And our person used to go at 6 o'clock in the morning. This Hamid, who has prepared some of the slides, he used to go at 6 o'clock and then get the component, fix it up, and then start the surgery at 8 o'clock. So this is how, and then if there is suddenly a technician is sick, we used to request somebody from Hyderabad or Chennai, we used to get somebody. So this is how we faced the problems in the initial, this was the road. In fact, in 1989 or 90, I accompanied one patient who is a famous film producer from Vijayawada when he had a heart attack because I was not having a cardiac catheterization laboratory. I handed over the patient, I went in a Dornier 8th flight, accompanied the patient, handed over the patient to Dr. Somaraj in the Johnson Institute of Medical Sciences. But now there is no need. With this machine, some people are coming from Hyderabad to get a 256 slice CT in our center now. These were the roads at the time, and this is how we started in 1996, the emergency, the cardiac teams, and then train people, and this is how and then there's another very important initiative, as I said, you can prevent 50% of the deaths, as I said, if a patient with heart attack comes within the first 1 hour, you can prevent 50% of the deaths. As the minutes pass by, every hour, every minute, the number of myocardial cells die, and whatever treatment you give, even if it is 3 lakhs, 4 lakhs, go and put a stent or do emergency surgery, patients are going to die. Yesterday we lost a patient because he came from Nasrapet. He went 24 hours after the heart attack to the doctor there, and then complete heart block, he was put on pacemaker, sent here, he stayed for 2 days, and then he died yesterday. We couldn't save him despite spending 2-3 hours with him. So golden hour, the time that is he was only 45-50-year-old. So golden hour, with your appropriate utilization of this, you can definitely improve the healthcare delivery for these people. We started the computerized ECG machines, 50,000 rupees at the time with GE machines, and then for 20 rupees we are doing in the periphery. Several thousands we have done, almost 95,000 patients got the benefit. So this is stroke awareness program, and if you treat the stroke, brain stroke within 1 hour, again with the injections, you can prevent permanent disability, permanent loss of speech, permanent inability to attend the office work. Within 1 hour, if you do similarly, just as a heart attack, you can dissolve the blood clot, you can put in a stent, and then you can establish the circulation in the brain, and then the patient can become definitely much better. Otherwise, otherwise you'll be bedridden for life. So these are all the programs which we have conducted. This was about 6 months, 1 year ago. After that, we are continuing this program, and we participated in the FDA, the research studies, and these are all the latest equipment. And then, some of the foreign patients whom we treated. We started all the pediatric patients we were sending to either Satyasai Institute or Hyderabad or Chennai. People were dying on the way, and we have conducted more than 220 cardiac surgeries in the past 1 year. We have started this program, which was very much deficient from all over the state now, from Vizag, from Anantapuram, Kurnool. People come to us, the pediatric patients come to us now. And this is the number of surgeries, and then with international quality, we were in Limca Book of Records in 1998 for conducting with 99.8% success rate in cardiac surgeries. Now we have completed these numbers with the team. We have a wonderful team, and who are staying with us for 10 years, 15 years, 20 years, 25 years now. And that team is the strength for the hospital. It is not the infrastructure and the equipment which we have purchased. These are all the telemedicine centers which we have in the network. We started 4 years ago. We were not having connectivity. We requested BSNL to have fiber to the home, FTTH technology given to us. And then now with the fiber grid, there is no need for all these things. So this is what it is. We have telemedicines, and as part of the public-private partnership, we started in Denduluru, Kaikaluru, Jagaipeta, and all these areas. We give free service, telemedicine service to the patients, conduct free camps for those areas every day. And we started in airport, we started in Central Railway, this telemedicine, and then in Kaikaluru, this area, And we started a new initiative, the post-discharge patient care. In the midnight, we started two-wheeler ambulances apart from the four-wheeler ambulances which we have. These are some of the patients whom we treated. I was talking about medical tourism. We had a New Zealand patient who underwent bypass surgery. Then we had a Russian lady who was lifted from sea for whom emergency angioplasty was done from Rajahmundry somewhere. And then this is another Belgium patient who had a cardiac arrest in the airport in Gannavaram. He was lifted and we did a radial angiogram after talking to the doctor there. And then on third day he was discharged, he went home. So likewise, there is a scope for medical tourism here and proper application of the healthcare delivery systems. Definitely the Andhra Pradesh can be a very important place, destination place for foreign medical tourism also. So thank you for the patient hearing. I once again thank the High Ministry for giving me this wonderful. Thank you for the patient hearing.
Friends, that was an